Hello and welcome to Health Matters on Channels Television. It's great to have you with us today. I am Mary Alale Yusuf. About 54 million lives were saved from tuberculosis between 2000 and 2017 through diagnosis, and the rate of TB incidence is declining at about 2% every year, according to the World Health Organization. However, the World Health Organization is looking for a 4 to 5% decline in incidences of tuberculosis in order to reach the 2020 target of the NTB plan. Very little time left. To achieve this, commitments were made at a UN high-level meeting in September 2018 to improve access to prevention and treatment, promote an end to stigma, and promote an equitable, rights-based and people-centered TB response, among other things. My guest is the desk officer for TB Network and the head of the Department of DOT Center at 68 Nigerian Army Reference Hospital, Yaba, in Lagos. She's also a director in the Federal Ministry of Defense. That's Dr. Margaret Okun. You're welcome to the program.
Thank you.
Okay, let's take it away immediately. Can you tell us what are the symptoms, defining symptoms of tuberculosis?
Yes. Tuberculosis, of course, they know it's a communicable infectious disease.
I don't think there's anybody who hasn't heard about it.
Yes. So, and then those defining symptoms that the common one we know is this cough for more than 2 weeks, persistent cough more than 2 weeks, maybe weight loss, night sweats. Sometimes you have a low-grade fever. Then, of course, we have some who will present with what we call hemoptysis, coughing out of blood, bloody sputum.
Bloody sputum.
Sputum, yes.
Of course, that would raise concern in anybody.
Yes. So, and then, of course, these are mainly symptoms of pulmonary TB. But there's another part, that is what we call extrapulmonary tuberculosis.
That means it's outside of the lungs.
Yes, outside the lungs. And the presentation depends on the site affected.
Okay.
Okay? We have, that is, TB can affect any part of the body. So when it affects the bone, and we will talk about the spinal tuberculosis, then we have, it can also affect the brain, where we have the meningeal
Are these
site.
common occurrences? Should we be concerned?
Yes, the extrapulmonary is not as common as the pulmonary. It's about 15 to 20% of all tuberculosis. But we have to be concerned because, like, the tuberculosis affecting the reproductive system can cause infertility. So it's a major concern.
Is it when the pulmonary TB has stayed too long that it starts to affect other parts of the body, or it just attacks anywhere at once?
It can attack anywhere, any site. You have some who have extrapulmonary who never had pulmonary TB. Okay. So it depends. Like for the reproductive one, it can be contacted through, sexual. Yes, if a husband had through the semen, one can contact it. And then we have the extrapulmonary TB mimicking other things. Like for the cerebral, you have this headache. Even some can present with convulsion. So there are some of these, non-classical, but the general public know about the pulmonary.
Yes,
everybody is talking
about
people cough, are used to. And they tend to forget that we also have tuberculosis affecting all the parts of the body. In fact, we even have of recent breast masses that were traced to TB, which people thought was cancer.
Would it be being too reactionary to say that check every pain? Yeah. Would that be in order?
No, yes, it's in order. Okay, you don't just overlook anything. But by the time you're like, for some people who have been maybe treating particular something and it's still persisting, not responding to the classical drug, think TB.
Okay, yes. Okay. So now, who is susceptible to TB? I know people who have reduced immunity and all that. But what kind of habits, modifiable habits, let's say, contribute to someone getting TB?
Yes. Like for smokers, Okay, they are susceptible. And of course, the environment, like those who are in crowded environments, like in prisons or the world schools, if there's an infected person, others can be affected. So, and of course, those with depressed immunity, like HIV positive, and then children below this 5 years.
Oh, children below
5 years.
They seem to be susceptible to everything.
Everything, yes. That is why when we have an adult that has active TB, we screen the children and place them on prophylactic drugs.
Oh, there is room for such a thing?
Yes,
prophylaxis?
Yes, we have. There is prophylaxis. And that's why we also encourage pregnant women that immediately they deliver, you give the children BCG.
Yes, I'm going to come to that.
Yes.
But first of all, let me ask you, yes. All these TBs, pulmonary, extrapulmonary, yes. Are they curable?
Oh, yes.
Good.
That is the good thing about it. It's very curable.
All right.
Once it's picked
in
time and then prompt treatment given, that's an appropriate treatment.
Okay.
Because now we have so many people who have, because they are hiding, because of stigmatization, they don't want to come up to be properly treated. They want to cut corners. They hide. Okay. And if they're not properly treated, of course, they go into resistant and multi-drug resistant, which is very, very...
That's another kettle of fish altogether.
Yes, and we don't want to get to that.
Okay, now this BCG vaccine is available.
Okay.
In fact, I happen to know that of all the vaccines, that's the one most used.
Yeah.
Because when a newborn, a new baby is, comes, first thing we ask is, have you got your BCG? As long as the baby is of a good weight, has the child got BCG, or else you don't carry the baby? People are so scared. Let's not give this child anything. So, if the vaccine is so effective, why is there so much TB?
Oh, yeah. You said the vaccine is to prevent, but that does not mean that one that has been vaccinated cannot be infected. But the only thing at the degree, the severity will be reduced. Yes.
Okay.
So the severity. So it's not a permanent immunity against it. Of course, someone who has been immunized, if you're exposed, you can contact the TB. You can contact tuberculosis.
So everybody is susceptible?
Yes,
then?
That's why it's not a respecter of persons. Anybody can have TB. Everybody is susceptible. So that's why we are very, very worried. We want to create awareness for everybody to know that this condition is deadly. It can kill if not properly treated, but it's treatable. So if people are aware, then they'll be able to access treatment early.
Okay. Now, if, let's say Mr. X has resistant TB, multi-drug resistant TB, and he coughs into the air, and somebody else catches the TB. Is it also multi-drug resistant in this new person, or is it, I don't know if you get my question. This is resistant in Mr. X. Mr. Y catches it. Is it resistant in him too?
Yes, the multi-drug resistant TB. Of course, if one is exposed, one can also get directly multi. But we don't just assume.
That means it's a new strain of TB.
Yeah,
with its own characteristics.
Yes, what happens that for the resistant one, that's why we remove them from the society. So once we pick that, we refer them. We don't even treat them in the general clinic.
Okay.
We refer them to centers where they are kind of restricted. They have restricted movement so that they don't spread it. But then, even if one is exposed to someone that has the multi-drug, we don't just assume that it's multi-drug, we'll screen.
All right.
So it's the result that will tell us whether it is...
Talking about screening, there are many tests that people have been talking about to find TB. There's one that we're all used to, which is the skin test. Then they talk about blood tests. They talk about chest x-ray. Are all these things correct tests for TB?
Oh, wow. Anyway, like for the national program, the ones we accept that is recognized is the acid-fast bacilli treatment and the gene expert.
Okay.
Gene expert is a new one, and it's faster and more accurate. So that is recognized by the national program. Of course, mantle test that you talk about, that one of the skin and all that, but that is not a standard that we accept. Even if one comes with that, we want to do it. And of course, for the extrapulmonary, that's where this other auxiliary tests coming, like the chest X-ray, like for the bone. We also have MRI, even CT scan, all other tests can come in for the extrapulmonary, depending on the site.
So what you're saying is that it's not enough to just do a blood test or to just do a Mantoux test on the skin.
No, it's not enough. It's not enough. So that's why when we have such, if there is a mass, like in case of TB, adenitis, we have swellings on the nose, in the neck, the nose, lymph nodes. Sometimes they rupture. We take sample from the site. Those extra, if there is
you do a biopsy?
Yeah, we do biopsy. That's why, like the recent one, we had TB appendicitis. Someone had ruptured appendix, and then histology. So histology has a role to play. So, and we discovered it was TB appendix, and then he was referred to us, and we started treating.
Why did he not come before the rupture?
He didn't know. He presented normally like a case of classical surgical case to the surgical department. They did the surgery, but the specimen was sent for histology.
Okay.
It was the pathologist that now found out that it was tuberculosis. So, that was so. There are other, especially for this extrapulmonary TB. Histology comes in, other biopsy from the site.
Are we able to handle every sort of TB in this country? Can we do it?
Yes, we can. We have the manpower, we have the facilities, we have the support. Like in the general one, we handle the simple ones. But for the multi-drug, there are specialized centers where
they are treated.
They are treated, yes. They are even quarantined.
Some people were saying that having a TB infection is different from having the TB disease. What does that mean?
Okay. Wow. Yes, like for some, some people are like carriers. They have it and they don't know.
Okay.
So by the time...
The latent carriers.
Yes, they're latent TB carriers. So they have it. That is why when we have any active TB patient, we encourage them to bring their relatives, friends, family members for screening. Because someone can have the organism without knowing, asymptomatic kind of TB. So, but most people know of the classical, he's coughing for 2 weeks and all that. But then, of note, we don't even wait. If one is HIV positive, we don't wait for 2 weeks.
Oh, definitely.
Coughing for even 2 days, you just refer.
Once the person is HIV positive,
yes, even
red
now,
alert.
Yes, now we even do active screening. We don't even wait for them to even show symptoms. When they come for their routine HIV clinic, we ask them, any night sweats, anything, weight loss, whatever. So we screen. So we now look for them and then treat.
In this end TB drive, are you calling for active screening for everybody? Because I'm thinking, if somebody is a latent carrier, then he's not going to exhibit any symptoms, so he doesn't have any reason to come to the hospital. But if you called for active screening of everybody, maybe at particular levels, because most people wouldn't just go for a TB screening. Maybe you want to go to school, screen. You want to get a job, screen, that kind of thing. Are you calling for that?
If possible, if everybody should go and screen himself.
Let us continue this after the break. Yes. We're going on a break right now. Join us on the other side. Welcome back. To ask questions about tuberculosis, the number to call is 0808-054-2233. That's 0808-054-2233. You can also tweet at CTV_Mary A. We're going back to the questions now and to learning more about TB. We're talking about active screening. Yeah. And you were trying to make a point.
Yeah. Because we discovered that the undetected TB is kind of the pool. Because right now, Nigeria is ranked...
That's the latent TB.
Yeah, no, even the... Yes.
And WHO says that's 1/4 of the world.
Yeah, the problem is Nigeria now is ranked 6th out of the high TB burden countries, out of the 4th high TB burden country in the world. And it's worrisome. And that's why we are so concerned. We're going out creating awareness for people to come forward and screen themselves. It's free.
Okay.
So you have nothing to lose.
Now, from what you've said, one of the major reasons why a person wouldn't want to come and screen voluntarily is discrimination. I don't know how people, get discriminated against because of TB. Can you just enlighten us? What constitutes discriminating against somebody with TB?
Yeah, most people, like what we observe, like some places of work, once they know that a patient has TB, most of them, they terminate the appointment because they are scared. I'm sure because of lack of awareness. They are scared of, like I told you, it's a deadly infectious disease.
Okay, so what would be the right thing to do?
Yes, the right thing to do is send them over. We screen and start treating. After 2 months, when we check and they are negative, they are free to go back to work.
Okay, let's quickly take Adebayo's call and we'll come back to that. Hello, Adebayo. We lost Adebayo, but please do try again. Mm-hmm. So you're saying lay him off for like 2 months or let him go home for 2 months.
For treatment.
If he takes it regularly,
yes.
He can resume.
Yes, he can resume.
And he will not infect
He will not
someone
infect
else.
Anybody. For most people.
But the treatment goes on after
Yes,
that.
the treatment goes on for 6 months.
Okay.
Except for the spinal, the bone one, and the brain. That one is for 1 year. Okay. But after 2 months, most of them convert. So, after 2 months, they are free to go back to the society. So most people, because they don't want to lose their job and then stigmatize, their neighbors will start running away. That one has TB. In fact, someone told us at a presentation that, in fact, in their village, once you have TB, they say you have poison or you're a witch or all that.
A witch?
Yes.
In 2019?
I'm telling you. So now we're trying to let them know that this is treatable. It's not, and anybody can get it.
And curable.
It's curable. So most people are hiding, and again, misdiagnosis too. So most people, because they don't think of TB, some people even die of TB. It might be at post-mortem, they now discover it's just TB, which is treatable. And these drugs are available. We screen free of charge, and the drugs are available free.
We have a call coming in. Hello?
Hello?
Hello. What's your question?
Good afternoon. Mm-hmm.
Yeah, I'm calling from Okota.
You are so welcome.
Yeah. How does one know if one has TB? Is it just by coughing?
Okay, we'll take that.
Or what?
Okay. Yes, thank you. Now, yes, like I told you, coughing is not the only one. That if you notice weight loss, night sweat, when everybody
weight loss, no explanation for the weight loss.
Yes, no explanation. One is eating well and you just notice you are losing weight. Think about TB. Some people can have night sweat. Everybody is feeling cold and they are sweating, even in an AC. So think about TB. And of course, apart from that, if there is a neighbor that has been diagnosed of TB and you are very close to that person, please come and screen yourself. So there are other things. Like I told you, like the extrapulmonary one, we have some people who suddenly lose mobility. They can't move. They have maybe swelling at the back, what you call gibbous. Think about TB. So go to the hospital, see your doctor. So there are other things, that, like I told you, depending on the site affected. It's not just cough. The extrapulmonary TB can manifest depending on the site affected.
Okay.
So,
now, one of the things that the WHO wants to do is improve access to prevention and treatment. Let me take Aliyu first. Hello, Aliyu.
Hello, doctor.
Yeah.
How are you?
Fine, thank you.
What's your question?
Yes, absolutely.
My question is this. I've been having this coughing for this while. If you go to come, but this time around, I've been having it for almost a month now. I've been taking drugs, working out, they're stopping. I don't know whether it's TB.
If you can see us at Yaba 68 Nigerian Army Reference Hospital, Dot Center, you can come over Monday to Friday between 8 to 12, okay? Come and we're going to screen you free of charge.
But of course, that's not a definitive
diagnosis. Yes, it's not.
But it still has to be checked.
Yeah, that's what I'm saying, that we have to screen. When we screen, we can rule out TB. Because this one, he said he's been taking antibiotics off and on for over a month. So you think about TB.
So, Ali, please allow me to use you as an example.
Okay.
I'm not saying you have TB, but let's just say you get a positive result.
Okay.
The next thing you'll do is tell his whole family to come, right?
Yeah, for screening. Yeah, we will start him. Yes, we will start him on medication and then get his family.
What about
contacts,
neighbors? Close contacts.
Close contacts.
Okay.
Yes.
Okay. So that's the way it's done.
Yeah.
Is this contact tracing kind of thing?
Yes, contact tracing. His immediate family, his place of work, or whatever. People who are very close to him, they should come for screening.
Once again, Ali, I apologize. I apologize. I am in no way indicting you.
Yeah.
All right. So now this access thing, you mentioned DOTS now.
Yes.
If I'm correct, that's directly observed treatment short course.
Yes.
Okay. And let's quickly take Adebayo before we go on. Hello, Adebayo.
Good morning.
Good morning, Adebayo.
Good afternoon.
My question is, when someone did test for TB serum and it's positive, then proceed to mantle test, and that one still reacted.
Okay.
But later, the person did chest X-ray.
Okay.
And it was normal. So can that person be confirmed to be TB positive?
Thank you. No. The person has to come to DOT Center. We're going to do another screening called Gene Expert. It is the Gene Expert that will confirm whether the person has Mycobacterium tuberculosis. And once it's positive, we'll commence the person on anti-cox therapy.
So what you're saying is that it's possible to get a false positive with all those other tests?
Yes, because like he said, chest X-ray was negative. You don't just say it's free. And mantle is suggestive.
Okay.
So, but mantle is not definitive. But when he comes, we do the Gene Expert where they will isolate the real organism, then we will commence. Okay.
So what is DOTS all about?
Yes, directly observed treatment short course. We discovered before the advent of DOTS, we discovered that most people were dying of tuberculosis. Like in Europe, like 1 in 7 were dying of TB.
Wow.
But with the DOTS, we observe you taking the drug because of the long period of treatment, 6 months. Most people, the compliance is always very poor.
Okay.
So we observe them taking the drug.
The medication.
The medication, because it's a daily drug.
Which means they have to come every day.
Every day, yes. But maybe because of traffic situation in Lagos, and we know how we modify it and all that.
So do you now have lots of DOT centers around the country?
Yes.
Because if somebody is really far away, he might default.
That is it. Okay. So we look for, in most cases, we look for a DOT center very close to your place, the place of abode, and then...
Let me quickly cut in there and ask for Elizabeth to speak up. Hello, Elizabeth.
Hello, ma.
You're welcome.
Hello.
Hello.
We can hear you. Go ahead.
Okay, I said where I did my IT before. Okay. So we work with these tuberculosis people. We work with these tuberculosis patients. So we screen them. Once we screen them, we monitor their health. But my issue is that we have to have a way of meeting churches or schools. Because most of the time when you tell people that try and check for tuberculosis, they say that God forbid, Holy Ghost fire, I cannot have tuberculosis. So if there's a way all these medical people can reach to the churches, reach to school, and it will create a better range of reaching also others. Thank you very much.
Thank you so much, Elizabeth. Isn't that a wonderful idea?
Yes.
Is it workable, though?
Yeah, we've already started. Okay? Only that, most of these things, you need a lot of financing. Yes. We've been going around creating awareness, sensitizing people. Some people will go to churches, go to schools, we invite them. But of course, we know it's not easy covering the whole. We need the enabling. It's a financial.
It's capital intensive.
Capital intensive.
Okay,
so,
let's quickly close. What can we do as normal everyday people to end TB?
Yes. So, to end TB, everybody must be involved about ending the TB. So we must be aware of the symptoms to look out for. If you see your neighbor coughing, please direct them. After all, it's free of charge. Okay?
Oh, yes, that's another thing.
Yes, don't look away and isolate.
You don't pay.
You don't pay. some people stigmatize, oh, that neighbor is coughing, and they now isolate the person, and they want to, no, feel concerned. If in the church or whatever gathering you notice someone coughing, advise the person. And in churches, please don't keep anybody that is coughing. If you know you are coughing, don't sit in the middle of the church.
Okay.
Sit very close to the...
responsibly.
Yes.
Dr. Okun, I'm going to have to tell you that we've ended this segment. Okay. Thank you so much for coming. This has been really, really helpful. Thank you for being there with us. And please, let's end TB together. Let's end TB. It's curable. Have a wonderful day. I am Mary Alale Yusuf.